Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have our presenters in conference. Please be aware each of your lines is in a listen-only mode. You may submit your questions electronically anytime using the Q&A pod located to the left of your webinar platform. You may also download a copy of today's presentation using the Resources pod located directly below the Q&A pod. It is now my pleasure to introduce today's first presenter, AJ moderator, Laura Castellanos. Please go ahead.
Thank you. Hello and good day, everyone. Again, my name is Laura Castellanos, Associate Director of the American Hospital Association, and lead our Hospitals Against Violence initiative. For this webinar series, we're very proud to partner with Heal Trafficking and Jones Day Law Firm. We've been working together for a bit over a year to bring a series of educational opportunities, very much like this one, covering a range of topics to support your efforts in human trafficking. Today's webinar, the health professional's role in identifying and responding to youth adults who are sex trafficked. This webinar will help health professionals understand some of the unique needs in caring for youth and young adults who have been or are being sex trafficked. Case-based scenario will be used to demonstrate some of the issues often confronted by health professionals. This webinar will also demonstrate the importance of utilizing a trauma-informed approach, particularly when addressing issues around mandated reporting, consent, and confidentiality often raised with this aged population. I'm very excited about this webinar. I do want to take an opportunity to just continue to raise awareness of the new ICD-10 diagnostic codes for human trafficking. They were started last fall. This was thanks to the efforts of the AHA, Catholic Health Initiatives, and Massachusetts General Hospital's Freedom Clinic. So we're definitely committed to continuing to raise awareness. But we also want to learn from what you are all experiencing in your hospitals, health systems, and health organizations in regards to this and how we can best support you. As you know, human trafficking is happening everywhere. We just want to make sure that we're being responsive to the needs of our membership and of our communities. So please visit our website. There's great webinars, fact sheets, and other key resources around ICD-10 codes. And definitely feel free to reach out if you have any questions or feedback as to how we can improve the value that we provide and the great work that you do. So now it's my absolute pleasure to introduce today's speaker. Dr. Tanya Chafee is a clinical professor of pediatrics at the University of California, San Francisco. She's also medical director of the Child and Adolescent Support Advocacy and Resource Center. This is a referral center for children and adolescents who are alleged victims of sexual assault for the city and county of San Francisco. Additionally, she's also director of Teen and Young Adult Health Center at San Francisco General Hospital, where she provides primary care for teens and young adults, including those who are victims of trafficking. She has served in numerous local and national organizations focusing on youth violence, and most recently she served on the Institute of Medicine's committee's report on the commercial sexual exploitation and sex trafficking of minors in the United States. Very glad to have Tanya with us today to share some of her work. So without further ado, handing it over to you, Dr. Chafee.
Well, good afternoon or morning, depending on your time zone, and I really want to thank those of you who are able to attend. As you can see, I've my title slide. I want to recognize some of my colleagues who helped contribute to this particular slide deck, which is developed through the Adolescent Reproductive Sexual Health Education Program in the Physicians for Reproductive Health, and that's what those logos are for. My colleagues, Aisha Mays and Vinnie Ciuliani, created this to sort of make it available to anybody as I sort of train the trainer. And I welcome you to go ahead and Google those organizations, and you can find the very numerous modules, including this one. This is actually tailored for this particular presentation, and I've modified it a bit. But you are all welcome to. It's an open access slide deck. It even has other things on adolescent and young adult sexual and reproductive health. Also, I just want to point out my email is listed in case you want to email me any questions. I do know that there's a lot of experts who are present today for this webinar, so I'm not going to choose to say that I'm a total expert in a lot of this, but I do welcome questions, and again, you can email me any feedback regarding this presentation. So as you heard, we're going to kind of do a little bit of an overview as what we sort of call red flags or signs of how this may present in the clinical situation, because the typical person doesn't come in saying, I'm being trafficked. It sort of comes in various forms, and we're going to review some of those common red flags. Along with that is, what are some of the common barriers that we see, particularly from youth and young adults, which are often can be different than how they present in older adults. And this can be really a significant issue around mandated reporting laws, particularly state-mandated reporting laws. I'm going to review some of that. Then I'm also going to talk about why it's important to look at this from not just a trauma-informed, I would actually almost use the language of trauma-sensitive response, and how healthcare providers and healthcare systems need to incorporate that in order to have appropriate responses. And that includes, what are the responses when you are making a mandated report. Now, I know that a lot of people want to also hear about labor trafficking, as I would too. And unfortunately, I was involved, as you heard from in the Institute of Medicine's report, so I know that there was very limited research even when that report came out in 2013. But with that said, there's even limited research when you look at labor trafficked youth and young adults. That because of that, there really aren't any good evidence-based healthcare responses for labor trafficked youth, particularly looking at the developmental needs of youth. A lot of the times what you see is the one-size-fits-all, which I don't really recommend, because sometimes the adult systems don't always really meet the needs of youth. And so we really do need more research, as well as some state and federal policies on addressing that, because even though there may be overlap between how between sex and labor trafficked young people, again, the one-size-fits-all may not really meet all those needs, and there is a strong need for that. I will kind of pinpoint a few things throughout the presentation around how there may be overlap with labor trafficked youth, but this won't be focusing on the specific needs of labor trafficked youth, and I hope that people in the audience can really look to this as a charge to do some more research and more policy development. So commercial sexual exploitation of children is a term that we use, and it's kind of been defined from the Trafficking Victims Protection Act. And the definition is a child under the age of 18 engaged in the purpose of sexual servitude, regardless of the absence of coercion, force, fraud, abduction, or manipulation. And the key thing is that there doesn't have to be proof in a child under 18 of force, fraud, or coercion for there to be kind of defined this legally. And one of the things that's really important about talking about CSEC is it's trying to really change the language and taking away the term prostitution. Even in my own county, they had young people who were in juvenile hall who were charged with, quote, child prostitution. And the problem with that term is it sort of implies that a child is doing this on their own, and they're voluntarily wanting to be sexually exploited. And where you see this changing, and it's sort of the paradigm shift that's happened in the United States, is that we're taking this away from sort of being a legal and a law enforcement sort of issue that has been in the past, and taking it and looking at it as more of a form of child abuse. Where that's kind of had problems is that child welfare usually addresses child abuse, and child welfare systems are not the agency that's typically used to dealing with CSEC individuals. But what you have seen, including my own state here in California, is the laws have changed and now define CSEC as a form of child abuse, and no longer kind of defining it through the legal system as child prostitution. So that kind of helps us understand some of the key things that we need to understand in using appropriate language, because what you hear, and even the media sometimes repeats this, and I think it's important if you're ever working or talking with media to sort of use the terms that don't sort of normalize and use colloquial language that can make this seem like it's just something that everybody's doing. Again, CSEC refers to the exploitation of children, not that a person's a child prostitute or a teen prostitute. And to avoid using sort of the pimp and daddy type of language and using the terms exploiter or trafficker, and not to use the term John, but use that as a solicitor and also an exploiter. And the purpose of this is that because we hear this from victims, is that we don't want to really go through normalizing those kinds of terms that some of the people who are the abusers would prefer you to use and to normalize. Again, victims and survivors the hard thing is that they may not identify themselves as either as being a victim or survivor. And so you may hear people say that interchangeably, that I don't see myself as a victim, I am a survivor. They may be in that transition. And the key thing about this is that those terms can be stigmatizing, and they may be looked at as labels. And I do want to put one thing about, I really am glad that we have medical ICD-10 codes that we can use to help track and to help identify within a patient's medical chart or to identify for billing purposes. But I think it's important as providers to understand that sometimes when those codes are used, the victim or survivor may not want those labels used in their chart. I know this anecdotally from some patients that I've had who saw that in their medical chart and asked me actually to remove them because they didn't want those labels. So I do want to just emphasize that. And sometimes it's important to actually talk to patients about what are the things that they want to be either labeled as or not labeled as. So when we talk about commercial sexual exploitation of children, some people have their sort of in their mind definition of what that is. This slide just points to many types of ways this can present itself. One thing I do want to point out is that survival sex can be a little bit of a difference, that it's not always this third trafficker situation. Survival sex may just be with the solicitor and the victim survivor that's trying to do something that's keeping them either housed or with food, and sometimes in the case of people who may be having substance abuse problems, using drugs. And there may be differences in who is involved in survivor sex. But this want to give you sort of a broad overview that it doesn't just include what people may initially think of someone on the street soliciting sex. So why does it exist? Well, one of the things that we sort of noticed about sex trafficking in general is that there's a little bit of overlap with what we see, or there may be risk factors that are associated with sex trafficking that overlap with child abuse and domestic violence. And I kind of talk to people that I see sex trafficking where we are now with the public health response and sort of how we're dealing with the healthcare systems. It's about 10 years behind where we are with domestic violence. The one interesting difference, though, between child abuse and domestic violence is this actually involves the exchange of money. And so with that, when you see how this is used, particularly maybe more organized crime or in gangs that are using other things like drugs and maybe even firearms, that's just this sort of system is much more lucrative. So there is this demand and there's a large supply. And so it actually is different than domestic violence and child abuse because there's an economy behind it and there's strong economic drivers, especially when you see sort of the wealth disparities that we have here in the United States, but definitely internationally. The other thing that's very challenging is both nationally and as well at state and local levels, there's very ineffective and kind of inconsistent policies and penalties for when this happens. But I think one of the interesting things, one of the strong drivers, not just economic, is that there can be this power and control dynamic that happens with someone who's involved in being sex trafficked. And this may or may not be the same as someone who's being labor trafficked, but you do see this quite a bit in those who are being sex trafficked. So when I was involved with the IOM, we kind of looked at the categories of what are some of those factors, and we know that there's sort of the individual level, there's the relationship family level, then there's the broader community level, and even the sort of bird's eye view societal level of what contributes to someone being involved. I don't want people to just get, one of the things that happens when people focus on risk factors is then it sort of gets translated to red flags, so it then gets translated into sort of these what identification tools to help us identify people. And the one thing is these are categories, but at the end of the day, someone could be not filling in any of these, little boxes and be involved in being trafficked or a victim survivor of CSEC. And I think it's important to understand that difference, because if you're assuming that someone's LGBT or someone who's been in foster care or someone who comes from a family that's, having drug issues or family members are not involved in a young person's life, that that person is definitely going to be involved in trafficking versus someone who doesn't have those things that also could similarly be involved in trafficking. But this is just to give you sort of an overview that I think is really important. And one thing I do want to say that's definitely been a transition within the last 4 or 5 years is, as you see, one of the societal risk factors is lack of resources. And I know that from my own clinical perspective, I had a lot of young people who may have been involved, and I didn't know where to refer, who to refer. There weren't agencies to help people. And I think that's now finally changing, and there are more local resources, particularly for young people who've been involved in commercial sexual exploitation. So another important thing, when I go to some of my own trainings on human trafficking in general, is there's a lot of focus on that initial identification. And really what that means is you as the health person or system has identified someone. But I don't think we look at where we're identifying them. This could be a person that has been involved many years before and is not now, but is clearly at risk for getting involved again. And I think thinking of it more as a life cycle, because you may be interfacing with someone who's at risk for being involved, is involved, may be wanting to leave, may have attempted to leave, may have left, and then may re-enter it. And I know this because I've interfaced with lots of young people. I had a young woman the other day who, she was in her young adult age, 23, 24, and had been involved when she was 13 and 14. But she actually came in for STI testing because she had to go make money to pay rent. And she knew she could make $1,000 in one night by going back. So I think it's important to kind of understand this as almost like a life cycle that you may be interfacing with the person at any stage. And one of the things that's been very challenging, and I think this is where ICD codes and identification can help, is we don't really know what the prevalence is. There's been some earlier reports that really haven't been validated, and I think it's important that we need to sort of understand this more. We also know that trans women, they're not as easily identified, but they are some of the highest risk. And that the other thing, as I mentioned, we really need to understand that this is a life cycle, and but also to be aware of how, if we do identify someone, how we want to label them and how we want to monitor them and make sure that if they've exited and are not involved, that they're not at risk for getting re-involved. And we'll talk more about that. So as the title said, we're talking about youth, but also we're talking about young adults. And I think it's important, and I bring this up because my own county that worked on developing a CSEC protocol, this is a countywide protocol. This was funded through our state, and it really was focusing on 18 and under. And a lot of us felt that we were identifying a lot of young adults who had been involved when they were youth. And the interesting thing is that sometimes psychosocially, young adults will present and have needs to have some of the same supports that they were when they were adolescents, but they may have aged out, quote unquote, of that system, like foster care or their mental health system. And sometimes those systems that may have been available to them when they were youth are no longer available to them for young adults. And unfortunately, our health systems kind of do the same thing. You get different referrals and everything if you're under 18 and if you're over 18, and I just want to address that because many people who have been involved may be involved as young adults and be in adult systems of care, however, they were involved when they were much younger, and that this can be very challenging. Even in my own state, the laws were changed around mandated reporting, and you are mandated to report a minor who's involved in sex trafficking, but not a young adult. And so there's issues around that as well. But I just want to bring that up, that the young adults do tend to fall more in the youth systems of care, however, because of logistics. Things are sort of divided by age, of 18 and over and 18 and under. So I want to talk about a case, and I know you see a picture here, but I want to talk, you'll see this case presented throughout the webinar, and we actually changed the photo so that it wouldn't kind of make people assume a certain gender-based kind of thing, but I just want to bring this up. And this is actually a semi-true case that's been changed for confidentiality reasons. So Lena's a 17-year-old. She's coming in for a pregnancy test. She's with another young female who wants her to be in the room with her. And as you reviewed her past medical history from your clinical chart, you see that she's had 2 previous pregnancies. She's also had a history of chlamydia and herpes and a couple of visits for emergency contraception. So before I go any further, I think, as I mentioned with the picture, it's really important when you first get that kind of reason for someone coming into your clinical setting to address the biases. And I say this because she's 17, we have our own biases around age. And to sort of just internally think for yourself, how would you treat her differently if she was 25? Even more importantly, she's coming in for a pregnancy test, so that's definitely a female issue. But what if she was male? And what if her visit was for a sore throat? And I bring that up because you may miss things. And the reason I bring this up is because it's very important to kind of understand your own biases and assumptions when you see a person and talk to them and find out their medical history, that their behaviors may play into your biases. And the key thing in that is that we need to address those biases, because those biases lead to barriers in care, and they also can increase stigma and ultimately lead to disparate healthcare outcomes. And I definitely know that with just talking about the aged population of adolescents. They have significantly higher rates of particular reproductive health outcomes compared to adults and young adults and adults. So as this case kind of just demonstrates, when, as I mentioned earlier, people don't come in saying that they're being trafficked, we kind of use these terms red flags on the initial presentation. Again, I don't want to say that if people have these things for sure, yes, they're being trafficked. But I think the way to think about it and the way we define this in sort of the healthcare system is, quote, that differential diagnosis. So you have someone comes in with something and you're thinking, could it be this, could it be this? So one of the things right away is you see a minor accompanied by a domineering adult who wants to speak for them. The youth may appear older than her age or his age. The behavior may be an indicator, very angry, aggressive, fearful, anxious. Not being a great historian, maybe not knowing their kind of location, where they are, and that could be due to lack of sleep, which I've seen on occasion with some of my patients. They didn't even know what day of the week it was. They may give a very scripted history and not be able to fully explain everything that's going on, and that should be, the history or the exam not making sense, or delaying medical care for something that they're coming into. As probably some of you know, this kind of is similar to how we look at young people who've been victims of child abuse. Also, the physical signs not really making the story of why they have an injury of some sort. Having very depressed mood or flat affect. Now, again, these are just some red flags to think about. When you look at the actual medical history, and this sort of is alluded to in the case, is having multiple pregnancies or abortions, particularly at a younger age, repeated visits for emergency contraception. For some of those who work with intimate partner or domestic violence victims, this can be something that's also where you'll see that, and it could be an overlap. Having multiple sexually transmitted infections. Personally, I've had all of my patients, this may have been a way that we got to this conversation about what was going on, including hepatitis C. I think people don't think that, but that is something I've seen that present this way. Having symptoms related to physical or sexual abuse, having other physical injuries, maybe not having a medical home or constantly being seen in the emergency department or various emergency departments. Some social history red flags: having a significant older boyfriend or girlfriend, not going to school or missing school, not having any personal identification. It can definitely, you see this with labor trafficking quite often. Having substance abuse problems, potentially having CPS involvement, living in a group home can be a red flag. And then again, if not making appointments or not able to follow up. And that's important to know if you are, especially myself in a primary care setting, not able to follow up. Some physical exams, and I actually, in learning this around like tattoos or things that I ask patients now a little bit about their tattoos, and we actually have now a tattoo removal clinic to help survivors who may want to have them removed. But they also may, the reluctance to talk about a tattoo. Some of it, like not being very, as I mentioned earlier, anxious, fearful, wanting to sort of rush the visit. Maybe checking the text on their phone repeatedly, or saying they need to leave, or having multiple phones, having hotel keys, having poor dentition and not looking like they've seen a dentist, either being severely malnourished could be another that could also overlap with labor trafficking. Having large amounts of cash, I had that happen to me the other day. A young person told me that she was able to make $200 from the evenings out with friends that she exchanged the sex for cash, not realizing that this could be leading to something more unsafe for her. Noticing bruises or burn marks or other kind of scars that may have been from old histories of trauma. Again, these are just a little bit of a summary, but there's things where you may want to follow up and ask the patient a little bit more. So knowing Lena's history, there's obviously some more things. And what is a ways that we do this in sort of, it's kind of, I would say, the hallmark of how we talk to young people is getting a nice, intense psychosocial history. HEADS is one of the acronyms that's used. Some people have shifted that to shades, starting with S, and the first S is for strengths. I'll use H, which is home life, and what we find out is that Lena lives with her girlfriend. She ran away from home when she came out. She hasn't been in school for the past year. She doesn't really have any hobbies or things she does for fun. She denies using cigarettes. She does have some alcohol, and she's been using marijuana every day. She's also used ecstasy on occasion. She denies being depressed, but she admits having to medicate to deal with stuff. She started having sex when she was 12, but she did not want to disclose how many lifetime partners. She identified as female. She's attracted to both males and females. She did attempt suicide a year ago, but she wouldn't give details, and she was hospitalized. And as I mentioned, strengths, I think this is always important not to just focus on risk factors, but really look at what our youth strengths are. That's how you can really sometimes find out what are those resilient things that can help a person help themselves. We knew she was doing well in school, but she needed to leave school to make money for rent. So as you see, the HEADS kind of helped provide a more broader spectrum of what was going on, and I really encourage people to use that when they're getting sort of a psychosocial history from youth and young adults. As you saw from this case, and this is, I said, a case, I've had actually a few cases like this, but it does address sort of she identified that as being bisexual. And a lot of people do overlook LGBT, and it's also, I think, underreported. And that can be sort of attributed to not only just being trafficked, but also being LGBT and that kind of double dose of stigma, particularly around if you are having to report things or, disclosing things that may be stigmatizing for the individual because of their gender identity or their sexual orientation. And that may be reasons for the underreporting. There are definitely, for trafficking, particularly males, limited resources for those that may be involved in CSAG. And with that, there may be a fear of persecution based on LGBT status, and including countries of origin, and biases for asylum for internationally trafficked persons, and we see that in labor trafficking as well. And as I mentioned earlier, trans homeless youth are some of the most affected and can have the highest rates of survival sex involvement. I just want to kind of put that out there to think about that, and that's how this case presents. So one of the things that I think that's important is how does this happen? And it can be very dynamic, and it can be through one or two of the sort of bullet points that you see here. With sex trafficking, there hasn't been a lot of research of what is the most common way, but it can be through one of these things. And peer recruitment can sometimes happen, and I'll talk a little bit about traffickers through group homes. When young people are in the foster care system, it can happen through seduction or coercion, maybe looking at sort of that intimate partner where they may be in a relationship and then it becomes more this coercion that develops. It can actually also be through violence and force. And again, this is what you know from the Trafficking Victims Protection Act, that these are the ways that this happens. For young adults, this is definitely something that has to be proved to show that this is what's happening and this is that the person's actually being trafficked, as opposed to doing doing it for like self-exploitation, survival sex. We do know that the internet has been a way that's been utilized more and more to recruit through social media and chat rooms. And it can even come from parents, quote, selling their kids or sometimes it may have been a parent that was involved themselves that now is involving their children in sort of being sexually exploited. One of the things that I know I don't see much in the literature or research is looking at who are the traffickers. This is an area that I think internationally has been looked at, but not as much in the United States, and I do think we need to understand this because again, of this economic driver behind this happening. And if you look at it from the public health perspective, we have a lot of responses to survivors who've been trafficked, but we don't have a lot of responses for the traffickers other than incarceration, and we definitely don't have a lot of responses for looking at the drivers of solicitors. But one of the interesting things I think that's important to know and that's seen internationally is who are the people that become the CSEC-involved youth are also those who may become traffickers themselves. And one of the reasons behind this that the literature shows is that if a person's being trafficked, if the person is involved in being exploited, they may become a trafficker to avoid being victimized and exploited. And that's interesting, particularly from the legal perspective, but it is sort of that path of least resistance. In order to stop being sexually exploited, they become a trafficker themselves or a facilitator. And you sometimes see that in the more organized crimes and gangs with this kind of social network happens within the trafficking situations. And this gets into then how does a trafficker manipulate someone? Sometimes it can look like this family structure, which can be something that a young person is missing, and so they find this, that they find this person becomes this sort of parental figure. And that can also set up some of this dynamic of these trauma bonds that can develop. It can often look like an intimate partner situation and some of that controlling and degrading behavior. And again, that gets into this power and control, which I'm going to talk about again. But it's really important for us when we're talking about being trauma-informed and trauma-sensitive to understand that power and control dynamic, that can play out in the healthcare setting, and we need to be aware of that. Because if you're not aware of that, you're not going to establish trust with a person. But if a person's coming from an intimate partner situation where there's a lot of power and control dynamics and controlling behavior, it can be very hard as another powerful figure like a healthcare provider trying to help someone. Sometimes it can play out in the indulgences. If you have a young person who's coming from a life where they don't have a lot of resources, they don't have a lot of parental sources, and this person that's trafficking them is doing that, like taking them out of school, taking them to get clothing that they want, buying things for them that they never had. That can be a very enticing thing. The other thing is sometimes drugs and alcohol can be used to manipulate. And I say that because I've had patients who've been, given lots of sort of amphetamine type drugs to keep them up for nights after nights after nights, and then they sort of develop an addiction, which gets into how you really need to think about how your response is going to be, including those types of resources. So as I mentioned earlier, particularly in the intimate partner violence situations, that you may see, when I first read the definition of Stockholm Syndrome and trauma bonds, it kind of really resonated with me. And I think you need to understand this to be trauma-informed, that how it's displaced is the victim survivor may show positive feelings towards their abuser or trafficker. They may actually help that person, and they may not be able to detach and do things to get away from them. They may have negative feelings for those people around them that are trying to support them, including us, the healthcare community. And it may be a reason why they continue to go back. And these relationships are set up so that that person will continue to be exploited and involved. I think that's important to understand, again, in the context of being trauma-informed. So what often people ask is, what are some of the questions that you ask to see if you can identify someone? And I think definitely asking is important. But again, you may have many, many people who deny that this is happening. So in this case of Lena, you ask if Lena is exchanging sex for money, drugs, or anything else. She says no. I don't say don't ask this, but I just want you to know that if a person says no, does not mean that they're not involved. And you often may get that response because, again, it's what they may not identify them as being involved with. They've been told to say no. And what we are starting to learn is that you may or may not get more of a disclosure if you are someone who is trying to establish trust, you are knowledgeable and trauma-informed, and you're coming across in a non-judgmental way. Those are words and terms I can say. It takes practice. It really has to kind of be something that you do regularly and try to have those conversations and set some barriers. And I think one of those ways is to normalize when you ask questions and kind of do it in a way that say, I ask all my patients these questions. And don't start just with the trafficking questions, but it may be around sexual behaviors. And then kind of going over what confidentiality is, which I'm going to address later. But I think the important thing is it's not to always get disclosure to identify, but understand that if you sense a person may be unsafe or if they're getting some red flags and you're worried about their safety, the most important thing is to have that universal conversation around safety, particularly those who may be more at risk or who actually have disclosed, so that you can support them in their next steps and empower them to understand that they're unsafe. For example, the patient I said that said she had just made $200, she was really, ecstatic because she needed the money, and a friend of hers had educated her about how to, exchange sex for some money, and she did not realize that she was in an unsafe situation. So I was able to help her kind of talk about that this may have been just a one-off and an easy situation for her to get some extra money. At the same time, I had to explain to her how I had taking care of young people like this, where it ended up more and more things became unsafe, and to be aware of that. And so that for her, that became that sort of light bulb for her to understand that this could be, a one-time thing, but it could lead to unsafe situations in the future if she continued to engage in exchanging sex for money. So this gets to some questions that can sometimes help. Now, again, none of these have really been validated and shown to be evidence-based, but has anyone ever asked you to have sex in exchange for something you wanted or needed, like money, food, shelter, or other items? Has anyone ever asked you to have sex with another person? And has anyone ever taken sexual pictures of you or posted such pictures on the internet? I think that's important because we do know that that's a form of exploitation, and people don't always think of that as one of the categories of CSEC. So obviously, if a person is being trafficked, they are going to they potentially have some health consequences, as this patient that I presented did. From the reproductive health, you do see some obvious. We've had in our own hospital probably a handful of patients hospitalized this past year for PID. We also have had a significant issue with a lot of our youth who are identified right now who are pregnant. Some of them are not wanting to be pregnant. A young person may have a chronic condition that's not being managed well. I've had patients with type 2 diabetes that had significantly uncontrolled blood sugars because they haven't been routinely seeking care. They may have infections that have gone untreated. They might have functional deficits, either from nutrition issues or physical injuries. Many, as I mentioned, sort of when you look at the risk factors, it obviously coming from families where there may have been other types of abuse. People may have experienced particular adverse childhood events or ACEs, and we know that those are associated with long-term health consequences. So if you are interacting with someone who is a survivor and it's something that may happen to them in the past, they may be suffering from some of those adverse childhood events later in their lives, and they may have some chronic health conditions where they do need to be in an established medical home and have primary care to continue to follow them, like hypertension and diabetes. And one thing that I do want to mention, and it is, survivors may not identify as being depressed, but there is definitely one of the worst consequences is the risk of suicide that I think is important to kind of always look at. And that kind of gets into some of the mental health needs, which usually are going to be complex. But I also want people to know that young people are very resilient, and they can sometimes often figure out how to help themselves. But this is where the referral system needs to be in place, particularly with mental health systems that are trauma-informed. And when we talk about complex trauma, it's not just PTSD, but there may be overlaps of other issues. And I know with young people that I've seen who may be actively involved, there can be sort of dissociation that happens, and they may have a flat affect and not really be responding to the type of traumas that they've experienced, whereas later on some of those traumatic things or those things that are triggering can come out later on. And one way that some people can cope if they haven't been forced to take drugs during their trafficking situation is they can develop drug and alcohol problems later on and need help for that, in addition to dealing with their other mental health needs. So when, again, a lot of people think that when we're interfacing with a person who may be trafficked, that it's that acute situation, but you may be interfacing with people who are out of it, and they may have some needs met, but they may need some more immediate or more long-term needs. And I just want you to think about that. In the acute situation, it may just be those, clear life things of housing and food, maybe whatever they're seeking the medical care for at that moment. If they're older and they have children, they may need child care assistance. The less immediate but not acute would be particularly legal status, helping them, doing some safety planning to make sure that they can get out of their situation and stay out of their situation. This is actually probably the trickiest time, because this is where I often see young people going back to their trafficking situation. It may be too hard for them to kind of leave the situation that they're in because they don't want to be back sort of out of the life. And where the stabilization can happen is helping them meet those social needs so that they can be more independent. Where I think a lot of these issues can be addressed more adequately isn't just by the healthcare system themselves. As you can see, it really does take a village. And in our own community here in San Francisco, we've worked at this, and we've developed a case management system that's kind of really worked at all these stages in the life cycle for a person who may be trying to get out of the life or exit, but is still at risk for entering it again. Obviously, from the medical perspective, there's going to be immediate as well as long-term medical needs. I think it's always important to address what they're there for. I noticed some of the participants are START examiners, and I can't emphasize this enough. There can be overlap with sexual assault and sex trafficking, and sometimes sexually exploited youth may be referred to a START center. And that's important to understand at the START center level, that you may have someone who's already identified, but again, as a START examiner, I know we have often identified people within our exams and interview system. And that the nice thing about START centers is they already sort of have that multidisciplinary team involved, including rape advocates, which sometimes can be that sort of case manager or person that can help coordinate the care later on. And I've started to see some more collaboration between those agencies that do respond to survivors of trafficking and working with START centers who have that kind of wheel invented of working with the child welfare and the district attorneys and the victim advocates to help them get the resources that they need. And if you are in a community that doesn't really have that sort of wraparound thing, sometimes working with your START center to help a person access some of those services through their START center can be a way to get. Centers are very, very trauma-informed. They may have direct mental health referrals with mental health professionals that are trauma-informed. And I think it's also, as I mentioned earlier, having drug and alcohol. From sort of the reproductive, and I can't emphasize this enough, I think thinking about screening, thinking about empiric treatment, obviously talking about kind of if a person's not desiring a pregnancy, the birth control, the options that are available to them. Talking about post-exposure as well as pre-exposure prophylaxis for HIV is very important. So long-term, as I mentioned, there may be some chronic conditions, or they're at risk for developing some chronic healthcare conditions, and that's where it's very important to have primary care involved in establishing a relationship to sort of do those follow-ups if possible, and considering things like PrEP, referrals to a trauma-informed or trauma-sensitive services. And even with this case that I presented, this case actually, the way that she was able to get services was she was being abused by her partner, and we were able to access domestic violence services for her and sort of the wraparound things that were available that weren't always available through other community agencies. Thinking about immunizations and definitely thinking about dental care is very important. As I mentioned earlier, it can be a red flag. So getting back to our case, when we asked more about Lena's relationship with her girlfriend, she admits that her girlfriend asks her to have sex with other men and has threatened her if she leaves, but is worried about her risks for STI and pregnancy, but doesn't want to leave her girlfriend. So how would you approach Lena in this situation? And this is some of the things that are kind of unique to youth. So as I mentioned, there aren't any evidence-based protocols in caring for CSEC, but there are some being developed. I think one of the key things in this, and someone who taught me, like, how do I know if I'm doing okay when I'm taking care of young people? And my mentor said to me, you're doing a great job if they come back to see you, because that sort of establishes that you've gained some trust with them. I think it's key to always go over confidentiality and the limits of confidentiality, which we'll talk about. And one of those is that mandated reporting categories. And I think the other important thing is that young people who are involved in being exploited often will need sort of a lot of other agencies to help and coordinate their care. It's always important if we even have someone who is identified or we're concerned about that, to treat what they're there for and then do safety planning. Again, the goal is not to identify. If they do, then it's really the same thing. You want to do some safety planning, similar to what we would do with intimate partner. And it's very important not to re-traumatize and get the whole history, because that may be triggering and that may make a person not want to come back and seek care with you. And we're really not trying to rescue them. We're trying to help empower them to help themselves, and doing that through sort of safety planning. So some typical questions that can be asked, and I'm sure people who are in this conference today have other ones to consider, are you being monitored by anyone? Is that person with you today? What would happen if you leave? Are you or anyone close to you being threatened? And again, these can generate some things that can help you think about some safety planning. Obviously, if and when you start to identify people, it's important to know in your community what the response is going to be, because you can't do this by yourself. And this is where the homework has to come in understanding what the local agencies and what their response can be. And even what the response can be now may be different 2 or 3 years from now. That they do need to come back and trying to work with, if you are in sort of a non-primary care setting, to partner with people who are typically used to caring for youth and young adults, or youth and young adult friendly situation that may have the resources like mental health that may be trauma informed to support the youth that you're referring to. And this is really important to develop those sort of multidisciplinary groups to define. And as I mentioned, sometimes the START Center can be that as well. I'm going to kind of review just a little bit on trauma-informed care, and I know many people are aware of this, but this is kind of looking at from the strengths-based approach. Again, knowing that a person that's being trafficked probably has experienced all kinds of levels of trauma. But the most important thing is to help the person again, that power and control dynamics, so that they have control on their situation and that they can make the decisions about what they want to do, and that we have to kind of ally ourselves with them to help make those decisions, because there are those power dynamics in the healthcare system. And that's why you may or may not get disclosure, is because a young person may know that their power is taken away when you have to go make that mandated report or do these other things that may not always be trauma informed. So some things that can, I think it's important when you're working with young people, to kind of avoid some of these things, or ask a person or explain to them why you're doing something rather than just doing it, like a gynecological exam or making them get undressed. Even drawing blood or taking a blood pressure may be triggering for some people. Explaining why you're asking questions, or say that you universally ask questions and that you want to understand, but it's not important that you share their whole story. And again, these are very important things to kind of just pinpoint some things that could be triggering for some people. So in Lena's case, based on what you've just heard, are you mandated to report this information, and what referrals and other services can you offer her given she's disclosed being trafficked? So this is one of the tricky areas, and usually where I get most of my questions, balancing confidentiality and mandated reporting. Consent and confidentiality. Across the United States, all states have laws that allow youth and minors to seek care around reproductive health. It can be for sexually transmitted infections, it can be for pregnancy testing. And what that means is they can consent to care without having to have a legal guardian consent to that care. States can differ on what levels of care that is, and that states' laws can change. but it's always important when you're talking with young people to go over confidentiality, because sometimes young people may be seeking care by themselves, or they may be seeking care with someone else, as in this case, and that they need to know that they have the right to talk to a provider by themselves and can consent to care, because they may not know that, and you may be the provider that educates them of that. But again, it's always important to go over limits, because in this situation, the mandated reporting part does become that limit of confidentiality where you do need to report other things. Why it's always important to room alone is to get into, we know this from research, that adolescents will disclose more about what's going on when you review confidentiality with them and when you're interviewing them alone, particularly around the sensitive questions. So using medically trained interpreters is very important, and sometimes it's important to actually, if you can, match the provider with the patient and having language congruity. So mandated reporting. All healthcare professionals are mandated to report forms of child abuse in every state. For C-sex, or sex exploitation, there's not as many specific laws around labor trafficking other than employment, but that's not necessarily a mandated reporting thing unless you're getting a sense of neglect or abuse. But for C-sex, there are actual states, including my own, that in California, that do require you to make a report to child welfare. In states that don't have that, there may be overlap around sexual abuse, particularly around statutory offenses and statutory offenses of getting into the age of the partner and what that is. Like a 15-year-old that cannot legally consent, they can really consent to have sex, it's a statutory offense if they're having sex with a 25-year-old. I think the most important thing is to know what the response is when you make a report. In our own state, when we identified someone, we would call child welfare, and they would say, oh, you need to call local law enforcement. We'd call local law enforcement, and they'd go, oh, you need to call child welfare. I think the laws helped clarify that. However, it's very important that if you have a young person in your clinic and you're telling them, I got to now call child welfare, the last thing they probably want you to do is to do that. And that's where you can see mandated reporting having some issues. I can anecdotally say that I know patients have said they didn't say what was happening to them because they knew that this would trigger other agencies being involved, particularly including their CPS worker. And this is where the balance needs to come in between their safety and what you're mandated to report in confidentiality. And I think the most important thing is that sometimes when that mandated report happens, it may not always be a trauma-informed response. And again, that can lead to more mistrust and decreased utilization of healthcare by the young person. And this is where it's very important to know what your response is going to be when you're calling your child welfare or your law enforcement, depending on what your local jurisdiction dictates. But I think it's also important about safety planning and understanding that you need to make sure that there's safety planning within your own clinic situation if you do make that report. So what I have learned is that when you're making that report, similar to what we do with like sexual assault in a minor, is to, again, do the safety planning like you would. And most importantly, this gets into the control and power, having that person be able to have a role in that reporting process and even speak to the report, the person that the report's being made to, and ensure that there will be a safety plan after that. And then trying to know what will happen. And most importantly, I think giving the person referrals and seeing whether they want to engage in that referral or not, or just maybe even having a follow-up. And again, understanding that referral to a SART service may be something that can help them get access to other services. I think just sort of the important thing about this, particularly for people who are not already thinking about this within their own clinical setting or healthcare setting, is to try to make this a priority and working with those stakeholders within your institutions that have the ability to set up protocols, is to train the staff, and that doesn't include just the healthcare people, but everybody in this, understanding what trauma-informed means, and then trying to figure out who are those agencies within your local jurisdiction that you might need to be involved with. And with young people, it may involve foster care in schools, but it also may include, the local district attorney, police, SART centers, and legal aid organizations. And then figuring out who those champions within your team are that can help develop that protocol within your system. And I just want to give a plug for the protocol toolkit that was developed by HEAL and Hope for Justice. It does help you think about all those things. You will see a lot of it overlaps what we do already with child abuse and domestic violence, but it is very specific for this setting. Some other things that can be helpful is having posters. The Futures Without Violence does have pocket cards and posters available, as well as the human trafficking hotline, as well as pocket cards to give and leave either in bathroom settings or in your clinic waiting rooms. And I think, again, what I want to emphasize in summary is that it's important of this transition that we're trying to do in the United States around CSEC in general is to take it out of sort of the law enforcement and legal system and really look at it as a public health issue and a form of child abuse. And that we know we are frontline players, and we may be the first agency that helps get a person the resources that they need to help them get out of being involved. And that the key to this is not always just identifying and rescuing, but it's really safety planning and assisting young people to get the care that they want, ensuring that the care that they are referred to is trauma-informed, and really doing the homework of knowing what your local response is. And if there isn't much of a local response, looking to other neighboring counties or agencies that have been involved in helping establish something like that within your own community. So with that said, I just have a few resources that I know many of you know of. The national hotline is definitely important, and this is something that can be given as a card to patients so that they can text or call. And HEAL, of course, has their, which you can download the protocol if you would like it. These are just a few other resources that you can utilize. The clinical report on CSEC goes over some of those red flags and other ways to respond, as well as the Institute of Medicine report that I was involved with. And with that, I would like to conclude the program, and I will be happy to take some questions. Thank you very much.
Thank you so much, Dr. Chaffee. I really appreciate such great information, and I know we only have a few minutes left. I want to encourage folks to submit if you have any questions on your Q&A box. I do have your first question. Can you please share the phrasing that you use in your practice when explaining limits of confidentiality?
Yes. So I always review this, or we have a handout that reviews it in the beginning, but I always review confidentiality when I'm getting to more sensitive questions. And again, those videos we have kind of really demonstrate that a lot on RSHEP. But the three things I say is, everything that we're talking about is private. I don't say the word confidential because some young people don't know what that word means. So I said private, and I said that I'm not going to share this information with anybody without your permission, but other healthcare people may know some of this, and that's protected. If there's any information about, one, you hurting yourself, you hurting someone, or someone having hurt you, and I'll get into specifics about that if they want, I need to talk to other people because that means that you're unsafe, and we need to work on safety. I've had patients actually say, I'm not going to tell you some things because I know what's going to happen with that information, which is, it gets me into this dynamic. And sometimes with those situations, I say, that makes me feel like you're unsafe, and we need to figure out how we're going to make you feel safe. And I have people that can help with that if you're willing to allow me to make some calls and so forth and so on. Hope that sort of answers the question, but it's a very, very typical question. It's something that we teach around what the limitations of confidentiality are.
Thank you for that. Next question, what are some of the approaches to working with youth who continue to run away from home?
We're actually addressing that in our own county. We call it the AWOL issue from group homes. I look at it as like another stages of change and where they are. You may have a young person who's, pre-contemplative, and some that are contemplative, and some that are motivated to leave. And it's, I think, just planting that seed and helping them get to that next phase. I think it's very important to get other people involved if you can, and you have resources in your community. We're fortunate we have a heart team that's a 24/7 response that will come out and meet with the young person. So I try to negotiate that, and they will continue to work with that young person, even if they've left back to their trafficking situation. They work very closely with a lot of the young people who are involved to sort of be that open door. I think that's the important thing, is like, I'm not judging what's going on, but I'm worried about your safety, and if you ever want to come back, here's my card, here's my email, here's whatever, make an appointment, and we'll talk more about that. You can't we can't change behavior, we can't change the situation, but I think being that non-judgmental, adolescent-friendly system that allows people to come back without any judgment is the most important thing, because that may be the place that they feel safe enough to kind of go to that next level. It's definitely an issue. I think one of the biggest issues is housing and where to place young people, because sometimes going to another foster care situation is not always going to work. I think a lot of places are struggling with that same issue of leaving back the situation. But I think it's important to know that, a person may not be ready to leave, similar with domestic violence, and you need to kind of plant that seed and help them if and when they do want to leave, give them the resources and information for them to be able to make that decision and be able to do it. Other questions?
Thank you so much for that. Sorry, I was on mute. We are at the top of the hour. However, I did want to just mention that we did get several questions around working with interpreters. So I don't know if you wanted to take a moment to just say how you do that within your practice.
Sure. This goes for everything, not just this. I sometimes ask the interpreter to say what they're saying before they say it to the person. Ideally, you want to match language and have language congruity, because I've had my own personal issues with all kinds of languages and misinterpretation of what the interpreter is saying. It can be an issue. I definitely do not recommend using family members and other people that may be more language, because there are a lot of medical things. But there can be issues with interpretation. And if you're having issues, again, what I usually do is have the interpreter actually say back what I'm saying, so that I can be clear the language is correct and that the words and things are being interpreted correctly on the meaning. And if you're having issues with a particular, we actually have a revaluation system of our interpreters now, so that we can really select the interpreters that are better with medical language and also sort of more culturally humble to some of the issues that may be addressed during a situation when you're using an interpreter. But I know that can always be an issue as well. I hope that answers the question for folks, but I thank you for that question.
Yeah, thank you so much. I know we're at the top of the hour. Didn't get to some of the questions from you all folks, and I just want to remind you that Tanya was kind enough to share her email address.
Yes.
We will be posting this recording in the next few days, and definitely encourage for you all to stay connected with our efforts to combat human trafficking. I don't know if you have anything else to share, Tanya, but I believe that will conclude our presentation.
Thank you. Sorry I went a little over and now time for questions, but I appreciate everybody being online today. Thank you.
And Stephanie, good.
Thank you, ladies and gentlemen. This concludes today's presentation. You may now disconnect.